Thank you, Ernie. Hello, everybody. I hope that the small crowd today is because folks are out with grandchildren, because I've been getting calls from people that they've already got grandkids in for the holidays, and I hope it's not the flu, because I've also heard from some people saying that they've got the flu, and I went, okay, we don't have time for that. So before I introduce our panel today, I hope somebody has already recognized the Sheriff's Department being here today, some of those men who are here today, and particularly Sheriff Smith. And I want to tell you all that we live in an incredibly bizarre time. I was brought up to respect law enforcement. Now, as I've said before, there are bad actors in any group. There are times that people just do the wrong thing. But I'm going to tell you, the undermining of the rule of law and the respect for law enforcement in this country is dangerous. Part of the reason we're having this program today is because mental health issues are not given the attention that they should be given in Austin and locally. This is the time of year that we should have a renewed hope in our neighbors helping each other. A renewal of those things that matter most. And something that really matters is helping people who are going through terrible mental health issues with their family members. The focus on that, those programs need to be effective and efficient. Effective and efficient. And that effectiveness and efficiency that we're asking for will help those families and those agencies that try to help, and ministries that try to help families who are struggling with mental illness. And it also helps law enforcement. Because I will tell you, I know from some past experience being an elected official and working with law enforcement, as I continue to do, that they are ill-equipped to deal with mental health cases in the jail. And that is usually exactly where many of our people that are struggling with mental health end up. So, when Doug McSwane called me and asked me about this program, I was eager for us to do it, and I want us to continue to work with them. So today we have with us Doug McSwane, and he is a local mental health care reform advocate. He has a very compelling personal story. Valerie Holcomb with the Andrews Center. Hi, Valerie. Valerie and I used to talk when I was a county commissioner. Fonda Latham with the Samaritan Counseling Center, and Dr. Jeffery Matthews with UT Health Center Northeast. Now, I'm going to ask you to please use the cards that you have on your table. If a question comes to you as you hear them speaking, please write that question down so that we can have the questions asked. But if you have a cell phone on, please turn that off. And please give our distinguished panel your attention today. And I would say, Doug, that if any of you all have materials that you would like us to have posted on our website, links on our website to important information, please would you provide that. You'll funnel that through Doug to me. We'll have that put on there. And also, as we approach the legislative session, if you all have some issues that you would like me to be aware of as I'm in Austin, I'd be more than happy to engage legislators on behalf of those things you all are working toward. So thank you all for being here today, and if we have some time at the end, I'll take some questions on the speaker's race and some other assorted various political issues, but give them your attention. Thank you so much.
So is my mic hot?
Give us a couple more seconds.
I think my mic's hot now.
as on behalf of this panel, we're really thankful to Joanne and to Representative Schaefer for helping arrange this panel for us to present the state of affairs as it exists for those who are dealing with mental illness and for families that are dealing with mental illness. Just as a start, how many of you in here have either dealt with mental illness, had family members or friends that have dealt with mental illness? You know, that's not unusual. Every place I go when I speak, the statistics are borne out. In our society, 1 in 4 have mental illness. If you extend it to the families that are affected by it, better than half of East Texas is affected by mental illness in one way or the other. And in most cases, those families go insular because of the stigma associated with mental illness. You can't tell somebody that your child is schizophrenic or bipolar or has anxiety disorders because people associate those type of things with violence, and they don't understand mental illness. They don't understand the causes and the fact that it is, in fact, an illness. Just like diabetes, just like cancer, and Dr. Matthews is going to explore that. But why do I know about mental illness? Because when my oldest son, Patrick, who was a very loving, athletic, creative, popular kid, was starting point guard at All Saints, went to Tech. But when he was 20 years old, I got a call one day, and he asked me how long I'd been in the mafia and when did I put a chip in his head. Well, I laughed, and then I realized he was deadly serious. And he had developed the first onset of severe schizophrenia. I drove down to Lubbock, Texas. I remember getting in the car. It was Father's Day. I took off down there to get him. And when I walked into his room, it was like a tsunami had hit it. I mean, there was food wrappers everywhere. It's hard to describe exactly what I found. He thought that I had a camera in the TV and was watching his every move. And so I brought him back, and that began my family's dark journey in that dark world of mental illness. For Patrick, he fought it for 9 years. He was a true warrior. He had schizophrenia. We went across the United States seeking help and treatment. We tried to utilize the legal system, but there's barriers that come with the use of the legal system. You have to prove that somebody's a danger to themselves or others before you can require them to take the only therapy that really works. There are others that work, but one of the principal ones is medication. Because as you're going to hear, mental illness is a actual genetic disorder that is a complex brain disorder. But anyway, with Patrick, we worked the system. You would think as a lawyer I'd know how to work the system, but the system is really difficult to manage. And on August 31st, 2012, after Patrick quit taking his medications again, and we begged him to take his medications, he took his own life. Many families in this area are facing these same problems. I get calls every week where there's been a suicide of a loved one, or, you know, my husband committed suicide and my 13-year-old daughter found him. So these are the type of problems that exist, and I wanted to educate you personally about the need. But I think in order to understand both the problem and how we deal with it, it's important to see what people who have mental illness, what they're dealing with. And I'm going to turn to Dr. Matthews, our psychiatrist, and ask him to explain mental illness and the causes and treatments, if you would.
I may have to stand up. I'm kind of a mover when I talk. I'm going to try to go real fast. I'm going to have about 10 minutes for my section, so this Oklahoma boy is going to talk as fast as he can. So if I go too fast, it's time for questions afterwards. First of all, as Doug said, mental illness is everywhere. We think about it, we see it in the news, Sandy Hook, college shootings, high school shootings. That is a face of mental illness. It's not the biggest face. The biggest face are people that you know, people, your neighbors, your friends, your family members, people in this room. It is a pervasive presence. Now, there is a huge spectrum for mental illness. In psychiatry, we use what we call a diagnostic manual. It's called DSM. And throughout that manual, when we look at a psychiatric illness, we're really looking at what problem is it causing with someone's life? What way is it interfering with someone's functioning? It's not the worried well, it's not a normal sadness or ups and downs of normal life, but it's an interfering with someone's life. And it can be a spectrum from people who have difficulty distinguishing the reality, people who have extreme highs and extreme lows in their mood, people who have crippling or disabling anxiety, people who have substance abuse that's destroying their lives. All those fit within mental health. Now, yesterday I had a talk with our new employees at UT Health, and my hour was on diagnosing and treating mental illness. And I kind of used them as a springboard for my 10 minutes today. So I'm scaling that way down. But one of the things that I really wanted them to understand is it is a problem, and it's a wide spectrum. It's not just what we think. It's a medical illness. We talk about the causes or what causes someone to have mental illness, and it's very complicated. There's a strong genetic component with most mental illness. There's a huge factor as far as exposure to toxic agents, exposure to trauma, stress. All those have an effect on how someone functions and how their mental illness is expressed. But you know, that's not that different from high blood pressure, from diabetes. Those are illnesses that have a huge component on people's diet, their activity, their genetics, their stress level. Those are chronic medical conditions, just like most mental illnesses. And our treatments are very similar. We don't have a cure. Just like diabetes, just like high blood pressure, our treatments are effective. They help manage the condition, but they don't necessarily cure it. And unfortunately, most of the illnesses in mental health are the same way. We're excited that we have a lot of very effective treatments. From, until the 1950s, 1960s, we really didn't have any medications for any type of mental illness. So to me, that's a short period of time. We've come a long way. But there's a lot we don't know, and our treatments aren't 100% effective. But they do help. But they are long-term, and they're chronic. Someone who has mental illness lives about 10 years less than someone who has the same health, biology, everything, except for they don't have a mental illness. It shortens people's lives on an average of about 10 years. And there may be a lot of reasons behind that. Part of it may be that the same condition that caused the brain disorder of mental illness is affecting other medical components of their life. Often it's because they're not getting treatment for their mental illness, and they're not getting treatment for their general medical conditions either. Unfortunately, sometimes the treatments that we have negative health effects. So you kind of come to having negative health effects for being untreated and compare it to having the treatments. And it becomes a balance of where do we do the most good or do the least harm. So those are kind of the overview of my view of mental illness. I know at UT Health there's a huge shortage in mental health treatment in Texas, in the United States, but particularly Texas. And in Texas, the shortage is greater in Northeast Texas. This is a shortage area. Our state hospitals are full. On a regular basis, they're full across state, and people who need admissions sometimes are transferred across state to get that admission because that's the nearest bed available. The state realized that, and there was a growing number of people in jails across our state that had mental illness, and they were stuck in the legal system because of it. They couldn't be charged, or they could be charged, but they couldn't be processed for their legal charges because of their mental illness. They were not competent or not understand the charges against them. So as a result, they needed treatment before their charges could be processed. They needed to go to the hospital. The hospitals were full. So the state opened up 30 beds at UT Health Northeast in March of 2013, just about 18 months ago, just to help reduce the burden in the state system. The people that came were people who really needed long-term care, and because they were in the state hospital, people were waiting in jails to get into the hospital. Last year, we chose to, or the state asked us to open up beds for acute care for people in our community. And in September of this year, we opened up a 14-bed hospital, or 14-bed unit, specifically to focus on treating acutely ill people in our community with a short length of stay and returning back to functioning as soon as possible. Those 44 beds are funded directly from Austin from the state system, just as we're funding beds in our state hospitals. Also in September, UT Health opened up eventually be a 26-bed, but currently we have 16 beds for geropsych, individuals 55 and above, and that kind of makes me nervous because I'm pretty close to 55. But, and those are for people that are in our community. It's more of a private practice setting, so we're providing both care in the public sector and the private sector now, and I just kind of want to let you know what we're doing. We hope to continue expanding. In Tyler, right now, my understanding there's one psychiatrist that accepts insurance. Longview, a similar sized city, is about the same, I hear. It's just a shortage of inpatient and outpatient, and eventually we'd like to expand and be able to provide more service for patients, for outpatients at the university as well, but we're starting where we started. I think it's about 10 minutes.
I have one question for you. A lot of people, when they view people with mental illness, they think all they have to do is just make up their mind to get better. Yeah.
I think Doug was saying it's a lot of people who have maybe that when they look at mental illness, their view or their advice is, well, all you have to do is decide to get better. All you have to do is make the decision that it's something that's in your control. And I think that's very prevalent. It's very common. Did I say it right? Yeah. My answer is a lot of things that people can do can help. One of our greatest benefits is that therapy is extremely helpful. For people who have mild to moderate depression, therapy we cannot demonstrate which is more effective, medications or therapy. When it gets to severe depression, the medications are more effective. But every time that we've tried to compare and looked at which works better, the group that had both worked better than either the medication group or the therapy group. We've done studies in the brain, and when someone takes medications and they improve with their depression, they have increased blood flow in the front part of their brain. When they're in therapy and their mood improves, they have increased blood flow in more of a back part of the brain. Both treatments are effective, they're both helping, but they're helping in different ways, different areas. And ideally, they work better together. So it's not just someone's willpower. That it's like someone has diabetes. Yep, you can diet, you can exercise. You may reduce your blood sugars. You may not. You may still need diabetes treatment. And the same things driving it, the same things that help people benefit apply to the mental illness.
Yeah. Thanks, Jeff. So, Valerie, turn it over to you to talk about the current problems that we have with the delivery of mental health services, the cost, and what kind of cost savings can we get?
Okay, thanks, Doug. I just wanted to let y'all know that I work for the Andrews Center, but I also have several different hats. One is the president of the National Alliance on Mental Illness here in Tyler, and also as a co-chair for an advisory council that provides mental health advisory information to all state agencies down in Austin and the legislature. So I come with a little bit of expertise and experience. All the data I'm going to give you can be found in research, empirical data, and so forth. So I'm going to talk about the cost. The cost, dollars and cents. I'm going to talk about the cost in human lives. I'm going to give you a scenario, and I want you to put yourself in this person's place. Is there any business owners here? Okay, and you have storefront. Let's imagine that you have a person that comes to your store or your business, and they're being a nuisance, and you want to just get rid of them. The first thing you're probably going to do is to call law enforcement. Law enforcement comes, they have a couple of decisions to make. They understand that the person is mentally ill, And they also know it'll probably take them about 30 minutes to an hour to take them to jail. Or they could do what might humanistically be the right thing and take them for treatment. That's going to take them probably their whole shift. So the most likely scenario is they're going to take them to jail for criminal trespass or some other nuisance offense. Now, he may be back on the street 30 minutes to an hour later, but the taxpayers are paying the bill. What happens is if the person chooses, the law enforcement officer chooses the hospital route, it's going to cost taxpayers roughly around $12,000. If they choose, for that same incident, if they choose the jail route, it's going to roughly cost them for that one incident $60,000. Okay? So yes, that law enforcement officer may be back on the street, but because the jails are a catch-all for those kind of situations, we as a society have chosen for law enforcement to make that available. Now, you're talking about $12,000 versus $60,000. And this is all data that's collected. Some of it is incorporated specific data here to Smith County, but it's all backed up by data. Some of the things, the other options is if you count that $12,000 plus about the $10,000 to $15,000 that it takes for 1 year to treat that person, it's half the cost if we choose treatment versus jail. But we have to have the resources to provide for that. The resources cost money, but it's cheaper. The resources that we're looking at doing is trying to create a crisis stabilization unit. That would be a local facility where law enforcement where the crisis stabilization unit would compete with the jail for admissions. It would take 30, 45 minutes to get that person in and out in a crisis. They could stay there involuntarily, meaning they can't go out into the public until their treatment gets to such a point that they're safe. Okay? Now I'm going to talk to you a little bit about lives, the cost in lives. At least half of the people shot and killed by police each year are believed to have a mental illness. In a paper for the National Sheriff's Association in September 2013, nearly all believed to be off their meds of those. 1/3 of shootings by cops are believed to be suicide by cop. Now, those are lives that could have been saved. Those are our brothers, our sisters, our family members, our church members. Now, just a question for y'all. This is a trick question. And the sheriff, don't answer this question. Okay? Where do you think is the largest mental health facility in the state of Texas? Just shout it out. Russ? Harris County Jail. If I had candy, I'd throw it at you, Mildred. Okay, where do you think it is in Smith County? Smith County Jail. I'm sorry, it's not UT Health Northeast. And it's not BHC. It's Smith County Jail. They're treating more folks for mental illness than any treatment provider in this county. Basically, we've essentially transferred mental health treatment to the criminal justice system. That's as I demonstrated, that's the most expensive to taxpayers. We need to change that. A 16-bed crisis stabilization unit. If you got more than 16 beds, then it goes into different licensure and stuff. But a 16-bed costs about $1.5 million a year to operate. And if you get more, then it goes into licensures and oversight agencies, and you really don't want to get to that point because then the costs go out the roof. So $1.5 million would treat essentially 688 persons a year. If you multiplied out that and you took away the availability of mental health treatment, that cost for using the state hospital system is $8.5 million. So 1.5 versus 8.5. These are the dollars, your tax dollars. The jail system, if you use this jail, $41.5 million a year. That's for 688 folks that we could treat in a crisis stabilization unit here. Now, the hallmark of a continuum of crisis services includes the crisis stabilization unit. The place, I call it a stop, drop, and roll type place where law enforcement can bring the person, family can bring the person, and they get their triage right there, admission right there, or if they do need a higher level of care, they could go to the state hospital. But the main aspect of it to be successful is that law enforcement needs to be back out on the street protecting and doing what they did when they decided they wanted to be a law enforcement. So crisis stabilization unit, mobile crisis services, which we do have, 24/7 crisis hotlines, we have that. Warm lines, we do have that. Psychiatric advanced directives, that's something else that we're looking into implementing more of, in peer crisis services. So the one piece, and probably the most essential piece, is that crisis stabilization unit. In case Doug's not going to tell you this, Texas is among the states with the lowest number of public psychiatric beds, and 49th in the nation for public mental health funding. And some other facts and figures. In 1840, the percentage of those in jails with a mental those in jails with a mental illness was around 20%. In 1880, after Dorothy Dix got a hold of their social work stuff, it was 2%. 1990, 7%. 2008, we're right back at 20%. So we're back. We've gone back to the 1840s. In 2010, state hospital beds, we have 2,400 state hospital beds. And give or take, whenever we partner with the private sector to see if we can add a few, but roughly 2,400. About 30 years ago, Terrell State Hospital had 2,700, as did most of the facilities. Most of the state hospitals are crumbling. So we've gone from about 100,000 beds to 2,400. Now, of that 2,400, 1,500 were civil, meaning those are the people who are wanting to commit suicide, that sort of thing, and then 903 of those are forensic. Somebody alluded to the forensic population. These are the people that are incompetent to stand trial or not guilty by reason of insanity. So what happens is, essentially, is if your family or loved one needs to go to the state hospital, you're going to be placed on a waiting list. And once you're placed on a waiting list, it may be 3 days, it may be a week. And that bed may be in Harlingen, El Paso, Big Spring, and then the sheriff's department has to transport them. And that's a very expensive transport. Plus, it endangers their safety because you've got to have 2 deputies, and they go out and they're driving overnight. They may have to stay overnight and then come back. So it's costly. And also, right now, the San Antonio State Hospital is on diversion for probably a month to 2 months because of staffing. They don't have staffing, so they're just closing admissions, which puts another burden on local law enforcement, on UT Health Northeast, and all the different psychiatric hospitals. Most of our hospitals stay on diversion. If you had a crisis, think about your children. If you had a child that was threatening suicide, you would have a hard time finding a bed. I have every single day, I have family members calling me, crying, what can I do about my adult child? Every single day. And it's sad to me. Not only that, but because I have this every single day, I've started to become more callous, less caring, because I have to say, I'm sorry, there's no beds available. Or I have to decide who gets this bed. Is it the person that is delusional, that might go blow up the theater? Or is it the person who's actively suicidal? Every single day we make those decisions, and it's hard. So we need help. We need lots of help. The mental health system is broken. Funding is one thing, but getting collaborations and groups together to support it is what we need. According to the economist Ray Perryman, for every dollar spent on mental health services, Texas would see a return of $23 annually. Have you ever seen a return on investment? It's 1 to 23. Have you? We're talking about 7 years, you might get 10% return, but we're talking about $1 spent, $23 in return annually. Per capita spending on mental health services in Texas is $36, when the national average is $100. The total impact is $269 billion each year because of behavioral disorders. $269 billion out of the economy due to lost wages, lost time, plus the cost of the treatment and the criminal justice system. Behavioral disorders lead to the largest annual losses in Texas in income and productivity. What we need is more local inpatient treatment results. If it's localized, then the family can get involved in treatment. There's better outcomes after they leave the facility, because guess what? The family's involved in the treatment. They learn just as as the patient learns. Also, there's a safety issue. Just read the headlines even this week. There's this public safety issue. So people are dying. I got so fed up about hearing about Ebola. Okay, we had 1 or 2 people die, and then maybe 4 or 5 cases in the United States, and everybody was up in arms. We went to California. We had to worry about catching Ebola on the plane. But the truth is, every 13 minutes, a person commits suicide. There's no outrage about that. And it's preventable. So, every day, we hear the same stories. Do these names ring a bell? James Holmes, Jared Loeffner, Adam Lanza. The same stories, all those things that we sit there and play armchair quarterback, our Monday morning quarterback, talking about these things. We can look back and see all those signs. Every single day in my clinic, I hear those signs and symptoms. It's just a matter of when somebody does the events like that. And that's all I have.
Valerie?
Yes.
Okay, I wanted you to comment on one thing. See if I'm coming hot. Yeah. So, right now, aren't we effectively treating mental illness on the back end with a revolving jail type treatment, whereas what you're talking about with the crisis stabilization unit would be intervening early?
That's correct.
And what are the results in terms of successful outcomes about intervening early? And is there communities in the state of Texas who have implemented programs where they get it on the front end and they deal with it at that time?
Yes, San Antonio has a stellar program. Also, the Burke Center, which is Deep East Texas, they have some pretty good outcomes with their treatment, and it's on the front end. It's that first contact with law enforcement or when the family members notice a crisis. The more crisis that a person goes through, the more episodes, the poorer their prognosis is for their treatment. So if we can get, Matt Schaefer asked us one time, he says, what if we made it easier to get folks into the hospital? And of course my response was, it's not a civil liberty issue. It's a resource issue. Basically, if we will free up, if we make more resources, we can get those folks in an earlier intervention. Right now, you have to almost be jumping off the cliff, and somebody's got to catch your hand before you can get into mental health services against your will. Does that answer your question?
It does. Okay. Fonda?
I think it'd be good for you to educate everybody what mental health services exist from a private sector, you know, like it's Samaritan Counseling, and then talk a little bit about why should we own this problem? I mean, is this something we look at and we say, oh, well, this is somebody else's problem to deal with? Why should we think it ought to be dealt with locally and is our problem? So I'll let you comment on those things.
Thanks, Doug. Dr. Matthews talked about this mental illness being on a spectrum, and a lot of the work that we do is on a different end of the spectrum than, say, the work that's done at the Andrews Centers and that Valerie does. We're often, as the Samaritan Counseling Center and those in this community who are private physicians, although we have a severe shortage of them, of psychiatrists, we literally have no place to refer many days, excuse me, except for to say, look at your insurance if you have it and see if there's a place in Dallas or someplace like that that you can go. We have good news. We have a new psychiatrist coming to town in the spring, so he'll be a fresh graduate. We're excited. I think his caseload will be full quickly. But there are private practitioners in town who do counseling with people. We have a few physicians. We have many primary care physicians and OBGYNs who are doing a lot of mental health medication in this part of the state because we don't have any other way to treat them. And in that case, it is just a manpower resource issue as much as anything else. One of the things that Doug asked me to talk about was just what's available in the private sector. And we do have some really good clinicians in the community. We have a few churches who have their own counselors. Again, we have a shortage of physicians, but there are some people doing some really nice stopgap kind of measures. We do have East Texas Behavioral Health, which is a private hospital that can provide some services. It's more of a short term. I do want to clarify something, that if people have resources, there are hospitals to be found. If someone's willing to go and if people have resources. There are hospitals in Texas, there are beds available, and there are hospitals across the country. The issue is it takes lots and lots of resources to be able to access hospital care. Sometimes insurance will pay, sometimes it won't pay. UT Northeast is a new resource in East Texas that we're really excited about having and looking forward to what that brings to our community as a whole. The Andrews Center, of course, has been here for a long time. And the Samaritan Counseling Center, we're about to have our 3rd birthday, and we are a nonprofit that is faith-based, and we are not faith-imposing by any means, but we integrate the whole of the mind, body, and spirit. One of the things that we've brought to the community by being a nonprofit, yes, we have people who pay full fee. Yes, we have people who we utilize their insurance, but as a nonprofit, we're also able to provide counseling to people on an adjusted fee scale. And we work very hard not to turn people away as a result of that. So when you ask the question, Doug, of why do we need to embrace it as a community, one of the things that I've discovered in my 3 years of doing this work in Tyler is that people will privately walk up to me and say, I'm really interested in this work because I have a loved one who struggles with depression, who has been diagnosed as schizophrenic, who's been diagnosed as bipolar. And much like you talked about with your family story, people still often stay insular, and they don't tell the story. They tell me very, very quietly, and they say this is very confidential because there is still so much stigma attached. So one of the things that we are doing as a community locally is there's way more conversation. In my 35 plus years in working in the mental health field, this is the most exciting time of people talking about what's going on and beginning to whittle away at breaking the stigma. Many of you know we had the Peace of Mind Conference in September, and some of you attended. And as we were talking about that, and Doug was like, I want to get this and I want to get that, and he's just this man of great hope, and he's quite the warrior. I told him if Patrick was a warrior, I know where he got it from. And I'm here to tell you, I'm embarrassed to tell you, but I'm going to confess it. If somebody had said, we'll have 300 people come out on a Saturday, I would have said, yeah, don't get your hopes up. So the fact that we had 800 people with a waiting list, I just kind of put it in the miracle category. Someone said, so what kind of miracle marketing did you do? I said, it was a lot of just people telling the story. It was as much of a grassroots effort and successfully done as anything that I can think of in East Texas on most any topic, but particularly at the level of mental illness. And that demonstrates what happens when we own it here. And coming out of that have been collaborative meetings with all of us that are interested in this topic and work in this field, and talking about what we can do in East Texas and beginning to get strategic about what we need to be doing in East Texas. And it's something that's come up and bubbled up and is going to happen, and it's going to be profound. It's not something someone could have mandated to us to do. It wouldn't have worked well. It would have, because each community has its own nuances, and we are going to be able to do something really powerful in East Texas, I believe, as a result of that. And there are people talking to each other right now that haven't talked to each other in a long, long time, if ever. One of the things, as an example of that, is that coming out of the September event, there were a number of congregations from this community that were represented, including pastors and leaders, and now several congregations are asking the question, how can we better minister to people who struggle with profound mental illness, especially, but people with all kinds of, along the way of the spectrum. And we're putting together a training in the spring for those congregations and for anybody that's interested in being more effective at being supportive and being peers, not to substitute for what Dr. Matthews might do or what Valerie might do or what anybody at our place might do, but to complement it and to go along with it. And that is going to help people get better and stay stable and stay out of the news. I mean, that's a big part of what happens when people end up in the news, is they've ended up often very isolated, and they don't have a community that they trust any longer that can say to them, we love you and you need help. They don't believe that any longer, and they've backed away and become very isolated. So we're hoping that getting a full spectrum of services is going to make a big impression in East Texas in the treatment of mental illness.
I have one thing.
Yeah, go ahead.
All right.
Yeah.
I just want to echo some of the things. That both Valerie and Fonda have said. It's a lot of times a case of a stitch in time saves nine. If you have a cut, you do not get that cut medically taken care of, your arm starts to rot off, you end up in the ICU, it is a lot more expensive to take care of that cut. But if you would have gotten it treated early, if you would have avoided the long-standing, I think that that's kind of sums up kind of what we talk about is where we're spending our resources. That a lot of it's where we're spending our resources and how we're spending it. We're spending the money. If someone is arrested and they are incompetent to stand trial, statistically they are incarcerated twice as long as if they had not been incompetent. So they're restricted their freedom twice as long. You're paying that bill. So we are paying that money, but how we're doing it, and I think our point is along the way is if we can be that stitch in time, we can really be much more effective with the resources that we have.
Just a second while my mic comes on. All right. We pay 3 times the amount that we would have to pay by dealing with this on the back end than if we dealt with it on the front end. We're also going to see a tremendous amount of good outcomes where people are treated in the beginning when their diagnosis, their illness is in the onset. You can really see successful outcomes in treatment of these people with mental illness. And then you're talking about the families. The families begin to understand. They begin to know how to deal with it. But I can tell you, since Peace of Mind, and you can access Peace of Mind and see the videos, in particular like Kay Warren. Kay Warren was tremendous. All the speakers were tremendous, but you can access it online and see the videos at peaceofmindtyler.com. And you can access it. You can see Kay Warren, you can see Matt Stanford, you can see Amy Simpson, and you can see Bishop Strickland, who opened it and blessed the event. And then you'll also see Dr. Dan Moorhead, a psychiatrist and had been at the Menninger Clinic. But it was an effective presentation. All 800 that were there were moved by it. But in particular, Kay Warren was particularly good, and I would refer you to that. But this is the sunset year, and I don't know if you realize it, but in sunset they're looking at the delivery of mental health services. So the state legislature is going to have to take it up, and we're going to need help in efforts to help the state leaders, the community leaders, understand the importance of us dealing with this problem on the front end rather than on the back end. We're going to need help in the creation of jail diversion programs and things like a crisis stabilization unit where we're going to see tremendous savings over what we're paying right now. Those are some of the specific things that we're going to need. So with that, I think we were going to open it up to questions.
Okay. This is for Valerie. What did you mean when you said Dorothy reduced the mental health load from 20% to about 6%? What did Dorothy do?
Dorothea Dix was a... Okay. Dorothea Dix was just a... I don't know her story very well. She was a rebel rouser, okay. She was somebody like me trying to get folks out of the jail and into treatment. So that was a movement back then to decriminalize mental illness.
Dr. Matthews, what is bipolar and what did it used to be called before the name bipolar was coined?
The old term is manic depressive disorder. There we go, manic depressive disorder. Bipolar is basically a word to say that they go to both extremes of mania and extremes of depression. And when I educate people about what bipolar is, the first things I say is, well, people who are becoming manic, they have less sleep. Sounds pretty good. They have more energy. They're more creative. They're more outgoing. They're happier. Unfortunately, that keeps going. They start believing they have special powers. They spend their entire savings on a harebrained scheme. They start using drugs. They start being promiscuous. They start speeding. They do all sorts of things that seem fun at the time. They're not using their usual judgment. They're not seeing any risk at all. It becomes a problem. You can see where it becomes a public problem as much as an individual problem. And then they swing the other direction. Extreme depression, unable to get out of bed, unable to sleep well, low energy, low interest. You know, depression is probably one of the world's leading causes of disability.
Is mental illness strictly genetic, or is our environment or foods, preservatives, etc., the cause or a combination?
There's a strong component of most mental illnesses. It depends really on the mental illness. PTSD, post-traumatic stress disorder, we believe it has to be involved with some traumatic event. It has to be some environmental trigger for it. However, we don't study the people who go through horrific events and do not develop PTSD. Past trauma, things that have happened early in life, increase the likelihood that someone's going to develop PTSD with later trauma. So it's really a combination. It's a combination of genetics. It's a combination of experiences in people's lives, maybe vulnerabilities, maybe the hand that they were dealt with. There's a lot of uncertainty about food additives. I grew up in the era that red food coloring caused ADHD. We never were able to fully demonstrate whether that was true or not. So that's a big unknown. There's a lot of people who feel that our artificial foods or things like that are really contributing to a lot of mental illness. However, when you look back at historical records, schizophrenia has been 1% in ancient times. It's 1% now. It's an equal opportunity, whether someone has money, no money, male, female, race. It's non-respecter, and it hasn't really changed much over time.
What percentage of inmates in this area have Alzheimer's or dementia? Alzheimer's especially can have damaging behavioral consequences to the victims and their families. Have you heard of TC-2153 and its effect on these two illnesses?
I don't know if we have that data. I don't know that specific to a certain illness that we have that data. The sheriff may know that. I don't know. Roughly, I could tell you about mental illness in general. It's roughly 20%. And if you take into account substance use disorders, it's closer to 65 to 80%.
I know that I was at Kerrville State Hospital, which is 100% forensic. It's 200 forensic beds in the Hill Country. And the largest unit is the Alzheimer's unit.
This is a follow-up. What percentage of bipolar is bad enough to really affect their lives?
I can tell you that according to the National Institute of Mental Health, that it's 6.8% in the population. That's the annual prevalence of bipolar disorder.
Did you have something you wanted to address to that?
I think it's a spectrum, and I think the difficulty is at some points in people's lives, it has a more effect than others. It's a chronic illness that has episodes that come and go. Untreated, those episodes get closer together and more severe as we age. But it really depends on I don't know the numbers as far as what percentage are having a significant or serious impact in someone's life.
What can we do as citizens to help?
Doug.
Just a second.
Wait till I come to Armando. What can citizens do to help? Number one is become educated in mental illness, and that's the start. You become educated, you understand the mental illness, and then you communicate to your elected officials, you communicate to the community as a whole, reaching out, helping everybody understand that we've got to address this problem and we've got to own it. I mean, there's one thing that this organization stands for, and it is that we don't solve our problems federally. We don't solve them even statewide. The best way is for the people to be the ones that are owning the problem, and the efforts are made locally to improve the situation. So that's what I think you can do, and that's why we did this program today, is to help educate everybody on the fact that we need things like crisis stabilization unit. We need jail diversion programs. Smith County can be one of the prime examples. You know, we know Lufkin did it, we know we can do it. So there's things that we can do and advocate for with our officials to help them understand the problem.
What y'all may not realize is that Texas has one of the most prescriptive, dogmatic rules for mental health treatment for the public sector. The contracts and everything, they make them so ridiculously rigid that it beats states like New York and California, those kind of states that you think that they're really dogmatic. They're pretty free for the local control over mental health. In Texas, there's hardly any local control over mental health for the public sector. It's very strict. And hopefully we'll get that changed, because we're under the same rules that somebody in downtown Houston has. Tyler, Texas has the same public mental health rules as Dallas, San Antonio. It doesn't all work the same across the state. And that's kind of counter Texas almost.
Why do more psychiatrists not accept insurance?
It's very low reimbursement. They have to keep an office open. I used to be a private practice psychiatrist early in my career, and I found that when people lost their insurance and they were unable to pay, that's probably when they needed me the most. And I knew that in a private practice office, I have to support my family, my staff, my overhead, my electricity, and it's really low reimbursement.
So what do? Lobby the insurance companies, or how do we assist?
I don't have all those
address
answers.
that?
I know that big part of it is it's a very easy group to not stand up for themselves. Our lobbying group for someone who has dementia, that's a mental illness that people understand. They can connect with, they can support. Someone who has mental retardation or intellectual disability, someone who has those difficulties, we can understand it, we can see it better. People who have mental illness don't have really a good lobby to stand for themselves. And there's a huge stigma, and I think that's part of, we talked about the involuntary treatment, and many people don't get treatment. It's twofold. Part of times people don't get treatment because it's not available. It's also, there's a huge stigma. If we would really work on helping people just understand that these are individuals that need help.
I would add to that, yes, working with our insurance industry in Texas would make a big difference. The Samaritan Counseling Center here is part of a national organization. I work with other executive directors, I consult in other states, and we have some of the poorest reimbursement across the country, both for Medicaid and for the public insurance reimbursement. So it's not just for physicians, it's for the rest of us, and it makes it very difficult to provide for the needs and the insurance providers.
Any of you have anything else to say?
Well, there is a law. It's called the Parity Act. And reimbursement rates for for psychiatric should be equivalent to that of the medical equivalent, but they're not. So if you ever come across that, some reason, you need to contact the Texas Insurance Board. I can't remember the acronym, but they're not getting those complaints. When we go down to Austin and we talk to the representative, they're not getting those complaints. They're saying parity is great in Texas because they don't receive the complaints. So if you do see where something's not reimbursed equally to medical stuff, you need to make that complaint.
A figure of $60,000 was mentioned as the cost of jailing an individual with mental health issues. What are the components of that cost?
I'm glad you asked, whoever asked that, because I wrote them all down.
Okay. Let's see. Book-in and magistration costs about $3,500 each incident. You got your calculator ready, whoever it was? Okay. The average cost of jail bed per day for an inmate with a mental illness. Okay, the average cost of bed day for a general population is like $45, $50. But for those with a mental illness, because you gotta treat them and you gotta separate them, $122 a day. Average stay for the scenario that I gave, where a person was showing up and they don't have the means to bond out, is 8 months. You add that up, that's about $29,000. But wait, there's more. Okay? They're incompetent to stand trial, so now they have to go to the state hospital. The forensic commitment is longer than the civil commitment. So you add all that up, court fees, the exam has to be a person that, and usually that professional comes from Dallas right now. That's about $1,500. You do 60 days in the hospital, that's $25,000. You add all that up, it's roughly $60,000 for one incident. Does that answer that question?
It could be a misdemeanor.
That's a misdemeanor. You or I do the same thing, we'd be out of jail in a couple of days. Maybe get time served. Yeah, maybe get time served. But we're talking about a misdemeanor offense. If it's a felony, you're talking over $100,000.
Let me tell you what happens. So when Sheriff Smith's deputies go out to apprehend the person who is urinating in somebody's rose bush out front in the house, that person has mental illness. Some mental illnesses really respond negatively towards authority. So when the person's in the midst of their psychosis, they see a police officer come, what do you think they're going to do? They do two things. They run, or they become violent a little bit towards the police officer. Next thing you know, that went from a misdemeanor to where now it's a felony. You take them out of jail, okay? And by the way, on the competence issue, a lot of times we're just trying to get them competent so they can come back and stand trial. I mean, you're treating them, but you're just trying to get them competent where they can come back and stand trial. Whereas you're not really prescribing full treatment for them on that. But now this person I got a record, and they go back out, and they've got nowhere to stay. Families, particularly a lot of families, I mean, it's 24/7. When you've got somebody that's a loved one with mental illness, it's 24/7. You never get a break. The stress in the household is so tense you can't cut it with a knife. You love your child, you love your parents, but it's a tremendous, tremendous effect on the families. For instance, my wife and I both have medical conditions that are significant, and it's because of the stress of dealing with our son 24/7 for 9 years. We love him. He was a warrior. We fought alongside him, but there's a cost. And we couldn't get him help. There would be so many times we tried to get him help, but we couldn't get him help. It wasn't there. And I had money. I had money to take him across the United States. But think about that poor mom over in North Tyler who's trying to handle 3 kids, and one of which has mental illness. That mom is who we're fighting for. And you're asking, what can we do? We can advocate. We can let people with mental illness know that no longer is there going to be a stigma. You come forward. There's not going to be a stigma. You know, only less than 1% of them are violent. And if they're violent to themselves. The situations like we see in Sandy Hook and Aurora, those are rare circumstances. But as a group, we need to stand and say, and that's what's happening in the churches that attended Peace of Mind. We've got a group of ministers that are coming together, and they're preaching from the pulpit, and they're telling the congregation, come forward. There's going to be no stigma. We're going to provide support groups. But if you take somebody with mental illness and you say, look, we're going to get you a vocational specialist, we're going to get you treatment, we're going to have you with a psychiatrist, and then we're going to get you a job. And you just work maybe 5 hours a week. We'll start out. We'll do that. The response of the person with mental illness to some support and some care is tremendous, tremendous. So that's just a comment I would make to what we can do.
How does one's being bipolar affect being processed for a crime?
Valerie, you want to take that?
I'm not an attorney, okay? But I can tell you that there is a law that says that if the sheriff's department or whoever is holding that person or anyone has knowledge that that person has a mental illness or displaying bizarre behavior, then they have to notify the magistrate within 72 hours. And then the magistrate has to determine, well, does it meet a criteria for being incompetent to stand trial or not, or just go forward. So I hope that answers that question.
Not only can the individual identify themselves, as any of the guards in the jail also can identify that this person needs mental health treatment.
And the standard that they're judging is whether or not that person presents a serious risk of imminent harm to themselves or others. We have one other criteria, that if they have become so debilitated that they present a danger to themselves. So there's 3 criterias. And, you know, I can tell you, like my son, okay, in the beginning stages of their disease, they can kind of hold it together. So when the police would come out, even though he threatened suicide, the police would come out and he would go, oh, no, sir, I don't know why my father said that. I'm not suicidal. I'm not thinking about that. Once we got him committed one time into Rusk, I can guarantee you he never used the word suicide, nor did he threaten harm to us again, because he knew the system. He knew the system. So there's going to come a time where we're going to have to realize that Patrick was not competent to make the decision whether or not to take medication. He wasn't any more competent to make that decision than he was competent when he was psychotic. And we would have to watch him go off his meds, go into psychosis, the whole time begging him to take his meds, to stay on your meds. That's your hope, son. And then once that happened, we knew he was in psychosis. It was just a matter of constantly trying to get him to take his meds or to seek treatment. That's the problems these families face out there. And if we go at it with an understanding that that's what these people are facing, and it's better than half the community when you think about it. If Tyler's 100,000, you're talking about 50,000 people that are dealing with this issue in Smith County alone, or Tyler alone. So it's something that we've got to address as a community to help, because the cost to us is significant, but more importantly, somebody mentioned in the very beginning about how we need to be caring and compassionate. Well, I believe that. And that's what caring and compassionate people do. They see a problem, they come in, they do their best to help those people, to help them. So the next time you see somebody homeless out on the street, you look at it and you go, what can I do to help that person? Rather than, oh, isn't it a shame that person's walking up and down Broadway pushing a cart. You think, what can I do? What can we do as a community?
A magistrate is a judge, in case you didn't know.
Are there specific judges? Our court system is complex.
She's asking what judge is the magistrate?
Well, that may be a question for our judge. Jason Ellis. Well, it depends on the day and who's doing the magistration that particular day. They take turns. It could be the JPs and so forth, the justice of the peace.
Jason, do you want the microphone to address that?
In truth, when it comes to mental illness, I think.
Well, wait a minute, they can't hear you.
I was going to say, she had it right that a number of judges will serve as magistrates. And I was going to say, when it comes to the legal issues involving mental illness, I think Doug, who's an attorney, actually knows it pretty well, probably better than I do. And a lot of that goes through the county court, not the county court at law. But of course, right, the commissioner's court, but the county judge. But of course, the criminal courts, as you've already addressed, deal with mental illness. Because so often, I as a defense attorney, as a prosecutor, I've represented and prosecuted a number of people who are obviously mentally ill. And it is kind of a cycle, like she said. It definitely is a cycle. You would see them, about as soon as they got out of jail, you'd see them again.
How do you deal with a person with a low IQ as compared to some type of mental illness, as compared to some type of mental illnesses? And in the case of schizophrenia, does it hit quickly?
I'll answer that. I'll take that one. Part of my career has worked with specifically people who have intellectual disabilities, and I really enjoy working with that population. One of the things I really enjoy working with it is the level of support that they typically have. When I saw an individual, they'd come to my office, their caregivers would come with them, and we worked as a team. And I enjoyed that aspect. Individuals with intellectual disabilities or low IQ have the same hopes, dreams, wishes, preferences to people they like and what they don't like as everyone else. Schizophrenia hits 1% of the population. There's probably a higher rate in people with intellectual disabilities because some of the same things that are causing their intellectual disabilities are affecting their seizures, they're affecting their brain functioning in other areas, and they have psychosis. Interestingly, people who have Down syndrome, the most common cause of intellectual disabilities, are less likely to be depressed than the general population. So there may be a little protective element, but for other causes of intellectual disabilities, it's an additive. So how I work with them is I talk with them individuals just like I talk with everyone else. I use language and words that they're going to understand, and I communicate them in that area. But some of the same things that we're looking for as far as what interference is this having in someone's life applies across the board.
Valerie, is there a mental illness support group for family members in Tyler?
Well, I'm glad you asked that. There is. The National Alliance on Mental Illness of Tyler does offer a group for family members. It's called Family to Family, and it's free. And I believe that we will have one beginning either late January or early February. And if you're interested in knowing an exact date or referring a family member or you want to come to it, just let me know. Or we've got some NAMI members here, Mildred Whitty. Just get with her and she'll give you the details on that. She's one of the facilitators. It's an evidence-based teaching curriculum. So, and it's highly recognized nationwide, and it's saved lives.
It's the only evidence-based course that's offered for this.
She's saying it's the only evidence-based course that is recognized by SAMHSA.
Can I add to that there's a new opportunity coming also through Grace Alliance that some of the congregations in town are coming together to do, and that will have a family-to-family component, peer support, as well as a separate group for people who struggle with mental illness, and that will also be a peer support-led group with a curriculum that was developed by a professor at Baylor and a couple of other people. So it's really solid material, and that will be coming shortly after the first of the year.
Valerie, what are the specific rules or laws that limit local responses to mental health issues?
Well, I'm going to say it's not laws, it's resources. because the law is pretty clear. Basically, what Doug had said, that if a person is at imminent risk for hurting themselves or others, or their mental illness is making them deteriorate to a point that they are a danger to themselves or others, then they should be taken for involuntary treatment. It's pretty clear. But what has happened is, because there are no beds available, or it takes 12, 24 hours to find a bed, is we're using other resources, the jail, or sending folks home on a safety plan. So the resources are what dictate how we're going to, that threshold of imminent risk. In those areas that do have resources, such as San Antonio or some of the other large facilities, when I talk to those places and I say, when I go out with them and I say, see who they're taking into the hospital, I'm like, we don't put those people in the hospital. They're not considered imminent risk in our area. And it's basically because the resources dictate that threshold of imminent risk. I hope that answered that question.
You compared us to New York City, and you said that we were so tightly bound, or so tightly prescribed by our laws and rules that we had limited flexibility.
Oh, okay.
That's the specifics that the question meant.
Oh, okay. I'm sorry, I didn't address it at all then. What I was talking about is the state contracts with private entities to provide mental health treatment. They're very prescriptive in how that delivery of service is given. You can only, I think, if you're at a certain level, you have to give 5.64 hours a month of treatment, whether that person needs it or doesn't. That's just an example. It's very prescriptive. That's usually not the Texas way. Texas usually is like, we're going to figure out how to do this ourselves in our local areas and do it and make it work.
Ma'am, I'm sorry. We're on a time limit here, and we do ask that they write the questions. What can a parent or a caretaker do to get help for a client that does not feel they need help? Any suggestions?
Who do you want?
Go ahead, Valerie. I'm going to comment on it.
Okay, a person with a psychotic disorder, whether it's schizophrenia or bipolar that's in an extreme manic phase, there's this thing called anosognosia. 40% of people with these disorders will experience anosognosia. That's where they don't recognize that they have a mental illness. And unfortunately, in the state that we live in, that, like I said, that person, if they're an adult, they're going to have to wait till they're right at the edge, if not jumping off, before you can actually give that, forcefully give them treatment. It's just a matter of being there, helping them. Maybe they can talk to somebody they trust, encouraging them, and maybe that family member needs to go through the family-to-family course to talk about ways that you can implement tough love measures versus where do you balance that enabling versus the tough love stuff. It's not an easy fix. There's a book called, Xavier Amador is called, what's the name of the book? I'm Not Sick. I Don't Need Help. Okay? That's a good book to start for that family member. But there is so hard to get help. When you can see that a person is headed for that cliff, till they get there, you can't hardly force any treatment on that person. And that we hear that all the time. Family members call me up, and I say, okay, bring them down to the Andrew Center. We'll do an assessment. Well, when that family member, if they come, they're going to say all the right things to where they don't need treatment. And there's no magic scan or blood test or anything. We just have to go off of what that person says. And that person can invite you as a family member into that conversation, but they can also say, no, I don't want my mother in here with me. And it's very frustrating for that family member. I have family members with mental illness that we've had to do involuntary commitments on, so I'm there with you. I'm a provider and a family member.
I've been told that our guest will be available if you have some questions you'd like to ask them individually. God bless you for the work that you do.
Thank you all.